podcast will discuss carotid plaque assessment during a carotid study. Let's review the normal structure of the vessel wall. The intima, or lining of the lumen, is made up of endothelial cells. It provides a structural barrier that limits the passage of large molecules. It also has a metabolic function and helps to maintain homeostasis. Endothelial dysfunction is the first step in the formation of atherosclerosis. Smooth muscle cells make up the majority of the media or middle layer of the wall. It provides structural integrity of the vessel. It produces elastin and collagen and helps to maintain that extracellular matrix. The adventitia is made up mostly of connective tissue and has a tiny network of vessels called the vasa vasorum, which supply blood to this outer layer. On the schematic drawing, the intima is indicated in red, the media in blue, and adventitia in green. Let's have a look at plaque formation. First of all, the attraction of lipids happens. LDL, or low-density lipoprotein, begin to accumulate and make the endothelium become almost sticky. White blood cells, or monocytes, show up on the site to help remove the dead or damaged tissue. This is an inflammatory response. The monocytes differentiate into macrophages, which ingest the low-density lipoproteins and become foam cells. These foam cells trigger the migration of smooth muscle out into the intima. If the fibrous cap, or this layer of smooth muscle, is thick, it is considered a stable plaque. Foam cells can become necrotic or have a lipid core. If the fibrous cap then becomes thin, or those smooth muscle cells are stretched, the plaque is no longer stable and is at higher risk for embolizing. When the plaque can actually rupture, and it can trigger the thrombolytic chain, narrowing the lumen and increasing the chance of vessel occlusion, or creating more of a thrombus that is at higher risk of embolizing. If it bleeds within that fibrous cap of the smooth muscle cells, there can be an echopore area seen within the plaque, and it may represent an intraplaque hemorrhage, different than a rupture. Let's have a look at a normal carotid. It has smooth vessel walls. The intima is clearly seen. The adventitia on the outside is quite bright, and the lumen through the center is anechoic. Let's have a look at an abnormal finding. I'm going to outline the smooth-walled, homogeneous, or low echogicity plaque. This is an area of localized atherosclerosis and is most commonly found at the carotid bulb. This particular plaque, a homogeneous plaque or type 1, has a high lipid content and are the most vulnerable plaques. Of course, surface irregularities are at an even higher risk of embolizing. A type 2 or 3 plaque is considered heterogeneous. It's a mixed echogenicity. I'm going to outline it here for you. It has a combination of fatty material and calcium. It may or may not cause attenuation or shadow, and again, irregular surfaces are at higher risk for embolizing. We would consider this a heterogeneous atheroma. A type 4 plaque is considered mostly calcific. This type of plaque is least likely to embolize. The majority is echogenic and is made up mostly of calcium. It's highly attenuating with acoustic shadowing. These types of plaques can be difficult for us to assess hemodynamically when they are larger or greater than 2 centimeters in length. Commonly in the lower mainland, we will refer to a plaque as a soft plaque, hard plaque, homogeneous, heterogeneous can be some of the terms used to describe the plaques. The type 1, 2, 3, and 4 are less commonly referred to out west, but for your Sonography Canada exams, you need to know that. Let's have a look at this plaque on the left-hand side of the screen. I'm just going to outline this smooth-walled homogeneous plaque. We can see low echogenicity in this area with an echolucent area. This can be that intraplaque hemorrhage that I talked about earlier and is contained within that smooth muscle. This could also be a necrotic or lipid core, fatty content. Until that atheroma is removed, we don't know the difference. It appears the same on ultrasound. On the right-hand side of the screen, I'm just going to change the color of the pen here. I want to draw your attention to this plaque along the edge of the wall. You can see that this plaque has an indentation or a depression within it, and it also, with color, demonstrates a little bit of flow reversal within that indentation. This is considered an ulceration. This isn't so much an ultrasound diagnosis as it is a histological one. So when they remove the plaque during an endarterectomy and look under the microscope, many of them have ulcerations. But again, an ultrasound diagnosis can be difficult. So remember our discussion earlier in podcast about the importance of aligning our color box to the region of interest. So notice how this vessel is diving and our color box is steered. And if we want to assess the bulb area, let's draw a line here. This is the direction of the color beam that's being transmitted. And then this is the direction of our vessel. You can see here that it creates quite close to a 90-degree angle of inclination. And we know that at 90 degrees, theoretically, no detected Doppler shift. There should be no detected Doppler shift. So let's have a look at the image below. The sonographer has steered the box the opposite way, or to the right of the screen, or towards the feet. Here's the direction of the transmitted ultrasound beam, direction of the region of interest of blood flow, and here is a nice small Doppler angle. So this angle of inclination allows us to pick up this area of aliasing. And in that area of aliasing, it would be important to walk or place our sample volume through this area and assess start to finish all the way through. And what we talk about is walking the sample gate. We're talking about walking it through this entire area, all the way through, listening for the highest velocity on our spectral Doppler. So here's an example above where the color box is aligned appropriately. We have our color box steered to the left of the screen. Here is the area of narrowing, or region of interest. So here is how the sound beam is traveling. And again, a nice small angle of inclination, and we're able to pick up the highest velocity flow. Notice in the image below, we're steered to the left, but if we really want to assess this area right here, this is creating kind of a larger Doppler angle, closer to 90 degrees. If we steered the opposite way, we would be better aligned to the region of interest. So it's really important to ensure that your color box and pulsed wave sample volume are aligned to flow. I hope this helped, and helps you to assess carotid plaques during a carotid study.